saturation at any point in time, he would actually go on to attempt to ventilate the patient with the various airway adjuncts. In this case, we incorporate training for both the Vortex as well as the Difficult Airway Society 2015 guidelines actually for managing the airway in these cases. In this particular scenario, he has already attempted intubation, he has failed. I've already marked up the knots at the offside already, I've cleaned and draped the area already and prepared and checked all my equipment in the double setup already in this case. He now says that he could not put the LMA, he could not ventilate and despite ventilate the patient and oxygenate the patient despite bagging the patient and using various airway adjuncts. He now triggers me to start the surgical cricothyroidotomy as previously agreed on. I will then proceed to the mannequin and start to do the procedure. So looking at this mannequin over here, alright, everybody can see very clearly, alright. Usually, ideally, we would practice also, incorporate into this also training. For example, we would shift the patient from a sniffing morning air position to an extended neck position if there's no evidence of any cervical trauma available. In most, for practical purposes, if you could put a shoulder roll, that would be even better as well for surgical cricothyroidotomy. But if that's not available, what I find useful actually is just to shove in the pillow, which you usually place under the patient's head, shove it under the patient's shoulders so that the head is left hanging out, and you get to achieve hyperextension very readily and easily in this case. Otherwise, if there's any cervical trauma, we try to avoid that as far as possible. You can still attempt to do the procedure, alright? Okay, so to do it, this mannequin, as you can see, you already can tell already, the layout is very important. In my left hand, I would have felt the landmarks. This mannequin allows you to feel the hyoid bone, the thyroid, as well as the cricoid prominences, okay? And this would be where, between the cricoid and thyroid prominences, where you would find the cricothyroid membrane. I have already marked out the site over here, okay? So to practice this, all right? So why is this very useful and very important to learn? Number one, you already felt the space, okay? It is in a well-felt landmark to the patient. You make a vertical incision through about 0.5 centimeter deep, all right, in this case. And now it's very important to learn, all right, and for procedures, because it sounds very intuitive, but actually it's not. You have to turn the blade 90 degrees, okay, towards the sharp end facing towards the feet. So let me just show that to you, okay? Don't do this, right? You're supposed to leave the blade inside. Turn it towards the feet. If not, if you put it this way, it's going to cut the vocal cords. So when you turn it this way, you pull this towards you, and you switch the hand. This is very important. This is actually not very commonly mentioned as well. We assume you just cut and you can put in a bougie, right? But my question to you is how are you going to reach for the bougie? Okay, so you have to switch to your left hand, all right, in this case, while you hold on to a lubricated a bougie with the bed tip going in first. This is a scalpel bougie technique which we try to recommend nowadays actually. And you pass the bougie into the trachea. So at this point in time with the mannequins, you can also have a tactile feedback for the entrance into the correct spot for the trainees actually. If you know you put the bougie before for any intubations, you would know you'll be able to feel the tracheal rings in this case. And I can feel it alright in this particular, in some mannequins as well, alright? So now that I've entered, okay, in this case I didn't require any dilation. So usually you do require a bit of dilation either with the finger or artery forceps if required. And once you have the bougie in already, now you keep it stabilized in place, all right, while you remove the sharp away, okay? Meanwhile, you secure with your non-dominant hand, close to the skin, the bougie. Your assistant will help you to railroad it very kindly, all right? Okay, and then you hold on to the other end. Oh, this is uncuffed, yeah, good, okay. And then we will then railroad the ETT through. All right, so this is usually a bit of you have to be very careful because if you notice over here, all right, this is the upper cuff. All right, there's a black line over here. Usually we try to put about 4 centimeters deep or 3 to 4 centimeters deep at least, all right, above the upper cuff. And I made a mental note before already that this will be roughly around here. Okay, so this, if I go in, all right, it takes a bit of strength already here. And this is why you need the dominant hand, all right. In reality, this one would be a bit easier to be fair, but sometimes you do require a bit of dissection to cut open or to pull open the tissues. Yeah? A bit of rotational movement and you're through. Right? So you do need a bit of rotational movement and you're through already. And now we're at the marking over here. Now holding the tube properly, all right, I will ask for the bougie to be removed. Okay? And now we'll cuff up the ETT, all right, and then we'll hook up the embo back valve mask, capnography as well, and then we will then begin a few series of checks. At this point in time, the ETT is still not secure, all right? So you have to be very, very careful. Someone has to hold on to the ETT at all times. It is very, very common that the endotracheal tube can migrate in or out or slip in or out very easily. So the auscultation and step whistle is very frequently missed and forgotten as well in the excitement, the heat of the moment after the surgical cricothyroidotomy. I think Alex and I, we had a recent experience as well with a recent surgical cricothyroidotomy patient And the patient, after the insertion of the tracheal of the ETT, there was capnography, but the patient persisted in the desaturation. So in this case, which is very important, is there was a bit of endobronchial intubation. It's actually quite common as a mistake in the heat of the moment when you insert the ETT in this case. So very good to check the positioning in this case, and to withdraw the ETT to appropriate. Don't put it too deep or too enthusiastically inside, because it will avoid any endobronchial intubation. Now actually then we will do a few series of checks. For example, make sure that there's an end-tidal CO2, you're not going through a forced passage, there's no active bleeding in the area, there's no evidence of any tension in pneumothorax. You're going to check the ETT cuff pressure as well to avoid any pressure necrosis, and you've arranged for a chest x-ray for the patient. And also you are now going to secure these sutures, which you can practice with this particular mannequin as well, to secure the ETT, which is a very important skill as well. So Alex will now show actually with other variations in the model and the mannequins that we can use to train for different types of scenarios.
Thanks, Sean. So as you mentioned, unfortunately, for some reason, two of us have always had difficult airways, and then he's always the one running to the ED, and then issues do arise. So we do have some practice. Focusing on the models that we have in front of us, small variations can be made to actually change the difficulty level for various learners. So as you can see, the one that Sean did was a little bit easier landmarking. If let's say we want to change it up, make it a little bit more challenging for more experienced learners, or someone who wants to practice with a patient who's a little bit with more subcutaneous tissue, a little bit shorter neck, a more challenging airway situation, what we can do is actually insert a silicone casted sheet, which is quite cheap and easy to be made, over the 3D printed larynx, and then place the skin over that. What this does then is actually it masks the underlying anatomy a little bit more, so that when you feel initially, you can start to feel the underlying structures but cannot convincingly feel the anatomy. What you then will have to do is actually create a longer incision over the anterior part of the neck. So carrying on that vertical incision, you would then proceed on to palpate after the incision, the landmarks before actually puncturing and doing the horizontal incision that Sean has so nicely demonstrated. So this is one example of how we can alter these various models that we have already. There are other models that we have, and I just like to make a key note here is that number one, all the models, the basis of all these models are all open access. We do not own the models, we did not come out with them. They're all done by very brilliant people, and they'll all be posted online. So they're free to download. You can just load it onto a 3D printer. Any grade is fine. So this has been printed with a hobby grade 3D printer that's commercially available that you can just buy online, all the way to a more advanced 3D printers where they can actually achieve quite good results, as the one that you can see that we're using over here. If let's say for some reason logistically it is a little bit challenging to get the correct 3D printer on board, what we can do is also just print a simple 3D larynx that is also commercially available that is also commercially available and open access as well. So what this can be done is we can place this over any of the AMPs that you have. You can place this on any of the recycled CPR mannequins or NG tube mannequins that have all been condemned.